Good evening, everybody. Without further delay, I will ask Salil Kumar sir to speak a few words, and we will go start the free paper session of pediatric ophthalmology.
Thank you very much, Dr. Jiten, and good evening to everybody present in the hall. We are going to start a very interesting session, and I'll request the speakers to stick in time. And first, I'll invite Dr. Sanchita Agarwal. She'll be speaking on evaluation of progression of myopia in relation to lifestyle and growth of children. Sanchita Agarwal, are you there? No. Okay. We move on to the next one. And this is Dr. Eva Rani Kalita. Are you there? Yeah. She'll be speaking on study of satisfaction and barrier for non-reporting on referral of child eye diseases. Number 2. ये किसका है? विद शुगर है ये? हाँ रेटिफाइड है.
Yes, thank you, sir. Good afternoon, everyone. Myself, Thank you, sir. Good afternoon, everyone. Myself, Dr. Eva. I'm going to present my study, PrEP 2, which is basically primary eye care in pediatric population, the second part. The first part of this study was done to know the clinical and demographic profile of pediatric patients who are presenting to 6 major vision centers in tertiary eye care center of southern India. And the second part of this study was done to know the satisfaction of the eye care services provided to the pediatric group of patients in the vision centers of Arvind Eye Care System, and also to know the barrier among the parents for not reporting to the base hospital when they were referred by the MLOPs there in the vision centers to the base hospital. So since the declaration of Alma Ata in 1978, the primary healthcare service has emerged as major milestone to achieve health for all across the globe. So when we talk about the primary eye care services, Vision Center plays an important part in delivering doorstep eye care services and is a key component to mission of eradicating needless blindness, and we follow the same at Arvind Eye Care System. But information on patients' perspective about the vision centers is very much useful for better understanding of utilization of eye care services and also the need of improvising the infrastructure. So there are numerous studies in the past literature where study of the satisfaction has been done in the eye care services, but these all, like major of the studies are done in the adult population. And to our surprise, none of the study, or there's a scarcity of literature on pediatric eye care services at the vision centers, and also the parents' perspectives on the same. So keeping this lacunae in mind, we did this study to assess the parents' satisfaction with pediatric eye care services across 6 major vision centers of a tertiary eye care hospital in southern India, and also to evaluate reasons for not attending the base hospital, that is the barrier among the parents on referral. So this was a prospective study of 6 months duration, and we included the study group in a pediatric population of 0 to 16 years. We designed standard validated satisfaction questionnaire, and the satisfaction factors that were evaluated were the accessibility of vision centers, the waiting hours, the financial aspects, the spectacle dispensing services, teleophthalmology services, and non-availability of dedicated doctors at these vision centers. Responses were assessed at a 5-point Likert scale, where a score of 0 meant very dissatisfied and a score of 4 meant very satisfied against each response. For statistical analysis, the responses were expressed as percentage with the score of 0, which meant very dissatisfied, and a score of 4 was given 100%, which meant very satisfied. Standard validated barrier questionnaire was also designed, and we evaluated the barrier factors like knowledge barrier, physical barrier, time barrier, and the financial barriers. In case of dropouts of the referral patients to base hospital, parents were inquired about the reasons of dropouts over telephonic conversation. So we got a sample size of 250 pediatric patients in a 6 months duration time. The satisfaction assessment showed that almost like 70% of the parents were satisfied with the vision center services provided to the pediatric population. But the most common reason of dissatisfaction was lack of doctor, or there's lack of the parents are not able to meet the doctor in person in the vision centers. So they were dissatisfied with that service. So when we studied about the barriers, we found that financial constraint was the main reason, because they couldn't afford to travel to the base hospital, or there was lack of transportation. The second most important barrier was a knowledge barrier, where the parents feel that the child condition might improve over time, or they didn't feel the need to report to the base hospital, or they felt that the child condition might improve over time, so they didn't report to the base hospital. So coming to the results, overall satisfaction was 75%, and the most common reason for dissatisfaction was lack of meeting the ophthalmologist in person. 14 out of 47 referrals didn't report and were evaluated using the validated barrier questionnaire. Majority had financial barrier, followed by the knowledge barrier. So coming to the conclusion of PrEP2 study, it demonstrated that 3/4 of the parents were happy with the services, but significant percentage wanted to consult the specialist at base hospital. 1/4 of total referrals didn't report to base hospital due to financial constraint and lack of awareness of the child's condition. Thank you.
So can I ask one question? You're saying that knowledge, they didn't have much of a knowledge. So what are the things that can be done to increase their knowledge, or how can we do it for the community so that?
Much of the awareness programs have to be encouraged, or the MLOPs have to be much more trained the pediatric service delivery.
No, how? Do you have anything, have you thought about it? You have just done it. So like giving informations and all it is going on, but
Yeah, ma'am.
have you any strategy for it, or?
Not for time being, which is just a recent study that we have done. So we are planning to do to implement more of the programs for pediatric eye care service improvement in the vision centers, ma'am. And most of the vision centers don't have the visual acuity infrastructure was not that much up to the mark for the pediatric eye care services, but it was like for the most of the adult population were covered in those vision centers. So we're thinking to upgrade those vision centers for the pediatric eye care services. Thank you.
The next speaker is Dr. Kavita V. The topic is analysis of orbitofacial anthropometry in children with features of pseudostrabismus. Can you see the timer?
No.
Is it visible to you?
Here also it's not there. Here also it's not seen. It was not seen there also.
That's why I was asking for.
First presenter when.
No, first presenter was not there.
Timer was not there.
I saw that.
Yes, start.
Do we go?
Yes.
Right. The cursor is, mouse is just moving on its own.
No, they are doing it.
Okay.
They're trying to put it.
I didn't see that. It was slideshow was there and.
respected judges and my dear friends. I have no financial interest in this presentation.
क्या हो गया फिर?
Facial anthropometry in children with features of pseudostrabismus. Which is the thing to move? It's not moving. ये वाला है ना? ये वाला. My time is going up. It down.
नहीं ये चलेगा. ओके ओके ठीक है.
So orbital facial anthropometry implies that we are looking into the measurements of inner and outer canthal distance, palpebral fissure width, interpupillary distance, and calculating the canthal index. Pseudostrabismus is appearance of strabismus in children. Actually, there is no true misalignment. This is quite often seen in children who have features like telecanthus, epicanthus, hypertelorism, and euroblepharon. These features can be present in isolation or in combination with various craniofacial or orbitofacial syndromes and congenital deformities and anomalies. So what's the importance of these measurements? It helps in diagnosis of craniofacial anomalies, orbitofacial syndromes and deformities, especially what we encounter is blepharophimosis syndrome, Apert syndrome and Clausen syndrome. It helps in management of these anomalies and deformities, especially so in reconstructive surgeries, also in lid reconstructive surgeries, so that it helps in better function and cosmesis, especially following trauma. Not alone that, it helps in genetic counseling of unaffected family members where there may be only manifest partial features. Other uses is in making of spectacle frames and lenses, optical display devices. Apart from ophthalmology, it is also useful in prosthodontics and forensic medicine in identifying of dead and living persons. Our aim was to analyze orbitofacial anthropometry in children with features of pseudostrabismus and to analyze these parameters in different age groups and between genders, and also to compare the measured and calculated IPD, that is MIPD and CIPD. This was a cross-sectional study and was done after obtaining Institutional Ethics Committee approval. Informed consent was taken from all parents of children. We recruited 60 children between 6 months and 18 years with features of pseudostrabismus, which I mentioned earlier. Children with lid and pupil abnormalities in whom measurements were not possible and with craniofacial orbitofacial deformities we excluded from the study. Also children with developmental delay were excluded. A simple instrument, that is digital vernier caliper, was used to measure all these parameters. 2 readings were taken by a single person. Canthal index, on the other hand, was calculated when we multiplied by 100 the ICD value divided by OCD. As early as 1983, Singh et al., one of the earliest pioneer in analyzing a regression formula for calculated IPD, he brought out this formula for male and female, which is as given below. So we use this formula to calculate the calculated IPD. There are other studies as well, foreign studies, but that was holding good for Western population. This is the only study available in India. Sub-age groups were less than 2 years, 3 to 5, 6 to 10, and greater than 10 years. Statistically, this data was analyzed. So as you can see, the central picture is showing to measure the IPT, the difficulty that we are having. But with the vernier caliper, when the child is sleeping, we can take the measurement much more conveniently. So there was male preponderance in our study, and the most common feature was telecanthus in 57%, followed by telecanthus with epicanthus in 10%, and hypertelorism in 2 children. When we compared the values between male and female, we found that all these parameters except calculated IPD was found to be statistically not significant between either sexes. We also had a subgroup analysis wherein when we compared between age groups, we found that all parameters except ICD and Canthal index in male and female were found to be statistically significant. ICD did not have much change with growth. That means this ICD, inner canthal distance, it changed till the age of 3 to 5 years. After that, it remained almost constant. What varied was the outer canthal distance and the palpebral fissure width. When we compared between male and female, we found all the parameters were higher in male. But in children less than 2 years and greater than 10 years, we found that there was significant correlation between MIPD and CIPD in both male and female. More so in male, it correlated very well. So other studies analyzed in normative data, but we took up children with pseudostrabismus. There are no similar studies. Additionally, we compared MIPD and calculated IPD. Measuring IPD is very difficult in some children because of poor cooperation, low vision, nystagmus, developmental delay. Therefore, CIPD, which can be derived from using a simple caliper, measuring ICD and OCD, is much easier than measuring IPD in these children. This can be used for clinical purpose only if we have a good correlation. We found a significant positive correlation between the two. There are no similar studies comparing these two parameters. Like any other study, our study did have some limitations. It was not a longitudinal study. There were no equal numbers in sub-age groups, and it was not compared with normal children. So to conclude, orbitofacial anthropometry values in pseudostrabismic children, we presume that it will contribute to the normative data, helps in retaining ethnical features following lid or orbitofacial reconstructive surgeries, especially so following trauma, and it can be used to counsel parents during follow-up that the squint is pseudo and not true, especially in children with pseudostrabismus features and post-squint surgery when we can show these measurements. Calculated IPD can be a simple alternative for spectacle frame and lens making in children where measuring IPD is difficult. These are my references. Thank you.
You said that features of pseudostrabismus. So how you diagnose that it is a pseudostrabismus? Just
After whichever, according to the age group, we do the clinical evaluation
just
for alternate cover test
correct.
or Hirschberg test. If we rule out that there is no deviation or phoria, then we take those children into consideration. But they should be having one of these features.
Yes.
Number what was the duration of your study?
This is a cross-sectional study, sir.
And did you find any racial preponderance of pseudostrabismus?
Racial is that I just considered in and around my place, sir. So about probably 200 to 300 kilometers.
Okay, but
it's South India, sir.
It's okay, but in South
Southern
India also
India.
many people from other places also reside there. So did you find any particular?
No, sir, I didn't find. Thank you.
up on the next one. So I would now like to call upon Dr. Shruti for her presentation on correlation of refractive errors with dry eye in pediatric population.
Anyway, I'll finish early. It's okay. Time is okay. Fine. It's okay. It's okay. Good evening, everyone. So I'm going to be presenting on behalf of my postgraduate here, and these are preliminary reports from the study that we're doing on a bigger scale. So this is a study to correlate the refractive error with dry eye in pediatric population. So dry eye is an important prevalent public health problem.
You are the chief author. You are the presenting
Yeah,
author.
yeah, yeah.
No, the study has been done
Done
by
by my
postgraduate, but
postgraduate.
she is, so we can consider for the award.
Yeah, I have submitted under my name. So dry eye is an important and prevalent public health problem, and we do find that nowadays children's tear film and ocular surface is being exposed to a lot of challenges like climate change, pollution, use of smartphones, computers, lack of sunlight exposure, and of course myopia treatments. So factors such as inadequate blink, inadequate refractive correction, poor sleep quality may also impact healthy children's tear film function. So when we looked at literature, there are studies which do show that there is a correlation between dry eye and refractive error in young adults, albeit at a very subclinical level. Smartphone using children also had a stronger preponderance with association with dry eye disease, and of course video display terminals use is an important risk factor for dry eye disease. There are also studies that talk about tear instability and worsening visual acuity and contrast sensitivity in children, and as high as 23.7% in school senior high school students. So against this background, we decided to evaluate the risk factors and correlation between dry eye and refractive error in a pediatric population. So we included, so the study is still going on, so we are presenting the data from 109 kids. Group 1 emmetropes and astigmatism, group 2 simple myopia and myopic astigmatism, group 3 simple hyperopia and mixed astigmatism, age more than 6 to 17 years with good systemic health status. We excluded kids who had any ocular surface disease or any symptoms, corneal ectatic conditions, strabismus, children who don't cooperate, and other systemic diseases. So we included patients who came into our hospital based on the inclusion criteria. We divided into 3 groups, and we had 70 myopes, 34 hyperopes, and 5 emmetropes. So we got an informed consent and a patient information sheet from the patient and the parent, and we did a dry eye evaluation with the Schirmer's test. We evaluated the T-beauty, tear meniscus height, and the corneal staining, and also the blink rate. So when we put out our results, we had Schirmer's 1 test was 27.5 average for myopics, 28 for hyperopes, and 29.25 in the emmetropic group. The blink rate was found to be significant. We found 8.92 in myopes, 12 in hyperopes, and 9.23 in emmetropes. T-beauty was 11.52, 17 in hyperope, and 11.47 in emmetropes. What we did find, however, though there was a small clinical significance, statistically these values were not significant. And this is the correlation of the refractive error. You can see the refractive error. One thing that we did notice was the higher the refractive error, the worse the Schirmer's value was, and this is something that we found across all the parameters. So the worse the refractive error, the higher the myopic refractive error, the worse was the Schirmer's 1 value. The same went for the blink rate. We could see that the blink rate was much lesser for the high myopes, and also the same for the T-beauty values. So these are our preliminary reports, and we found that though they were statistically insignificant, clinically we did find a difference between them. So we are working on collecting a higher sample and presenting the factors. So definitely increased usage of smartphones, computers, they play an important role. Preventive measures and environmental modifications can reduce the risk of pediatric dry eye disease. Thank you.
Any working hypothesis you have why higher refractive errors children have lower blink rates or lower Schirmer's?
Sorry, sir? I
So
don't-
you said that
Huh.
when the refractive error was high,
higher, the blink rate
Was
is
lower.
lower, yes, sir.
but any working hypothesis you have made, why should that be?
Well, I think it's the other way around. Because of the lowered blink rate, the dry eye disease.
No, no.
progress-
I'm saying why should, because if it is for myopia, it is understood that they are putting drops, or if it is myopia, they are watching terminals or they are
Yes, yes,
seeing
sir.
television or something like
Yes.
that. Why should it occur in hyperopia or astigmatism? I'm not, it's not part of your study, but if you
Okay.
have any working hypothesis why this is happening.
Well, I don't have a working
Maybe
hypothesis.
next
Maybe
year.
if there's, yeah, I would,
Yeah,
if I
sure,
can
sure.
work out
Not a
something,
problem,
definitely I'll
not
bring
a
it.
problem.
Yeah, this is just an observation that we did find out, but we
But
need
it's
a
a
much
unique
higher sample
observation,
size
yeah.
in order to reach the statistical
How did you
significance.
calculate the blink rate?
So we kept on 1 minute, and then we asked the child. We just observed the child as they were seeing the waiting in the waiting area. We didn't tell
Okay.
the child that we were noticing them, but we had one person who was appointed to stay there and watch the child as they were waiting in the waiting area. Thank you.
Did you count incomplete blinks also? I mean, blink rate means
A complete,
Complete blink.
Yes,
Okay.
yes. A complete blink was noted. So we trained the person who was observing before we started teaching them for that. Thank you.
You excluded cases of strabismus from your study.
Yes, sir.
Any
Yes, sir.
specific reason?
So we just didn't want any other any other confounding factor in that.
Yeah,
So,
but do you think the strabismus can affect this dry eye?
sorry, sir.
Do you think strabismus itself can cause this?
Well, strabismus there's a possibility that it can cause a double vision or something, and that could alter change the maybe the blink rate or something. So we didn't want any of that to affect the readings.
Okay, thank you.
Thank you, sir.
So the next paper is on molecular genetics and clinical characteristics of ocular disorders in children by Dr. Nilupat Deori. She's there? Yeah. इसका molecular genetics question पूछो। हाँ, वही तो।
I'll press this. I'll press this. Should I press this? Okay. Good evening, everyone. Today I'll be speaking on molecular genetics and clinical characteristics of ocular disorders in children, the mutations, variations, and the complexities involved. I do not have any financial interest in this presentation. As we all know, almost 50% of pediatric blindness is due to a genetic etiology, and eye being only the second organ in frequency of involvement. The central dogma connects the DNA sequence with the phenotype. And the SNPs, that is the single nucleotide polymorphisms, along with larger size sequence changes like deletions, duplications, create all the richness of human genetic diversity at the population level. So the purpose was to analyze the mutations and systemic associations of ocular disorders of childhood and establish a definitive diagnosis on the basis of molecular genetics and clinical characteristics of these patients. The algorithm that we followed was a multidisciplinary approach, and then we went ahead with the whole exome sequencing of these patients after a written consent. The results of the DNA was analyzed, and on identification of any variant, we went ahead with the eye screening on regular basis of these patients as well as their relatives. So this is a 6-year-old girl who was born to a healthy, non-consanguineous parents, and she suffered from a corneal limbal tear only after a trivial fall. So on repair of this patient, we found out an atrophic scar in the limbal area, and she was suspected with Marfan syndrome, but her general examination did not point towards Marfan syndrome. So at 1 year follow-up, you can see that the Batten score increased to 5 out of 9. There was skin hyperelasticity and episodes of recurrent respiratory complaints. Echocardiography revealed an aortic root dilatation of 17 millimeter. As you can see from the pedigree, it was consistent with autosomal recessive inheritance, and there was a frame shift deletion at exon 12 of the PLOD1 gene, which actually encodes for lysyl hydroxylase. So an Ehlers-Danlos syndrome of kyphoscoliotic type 1 was detected, and ocular and scleral fragility are although the most notable features of this disease, but they are rarely reported or they are failed to see on during or overlooked during routine examination. The most life-threatening complication of these children is aortic root dilatation or dissection. dissection. The second one is a 12-year-old girl born of consanguineous marriage. She maintained an uncorrected visual acuity of 6/9 but suffered from nyctalopia for the last 4 years. And when on dilated fundus examination, we saw discrete uniform white dots with greatest density in the mid-periphery but spared the macula. They were fewer in number with low autofluorescence signal and absent rod responses on dark adapted ERGs. The sequence of inheritance was an autosomal recessive, and there was a nonsense variant at exon 4 of the RDH5 gene, which actually pointed towards fundus albi punctatus. This was in contrast with retinitis punctata albicans, which was progressive in nature, but the most important point that we had to see here, or that was concerning, was these patients without macular lesions can sometimes progress to cone dysfunction. This is a case series of 11 children, of which 4 had suffered from upper eyelid coloboma, microphthalmia, and triangular growth of hair extending from scalp to the eyebrow with a symblepharon, and they were of unaffected non-consanguineous parents. The absence of syndactyly or anomalies of urogenital system on ultrasound was absent. So as you can see from the pictures, the only child who had some amount of visual acuity was one of the twins from the pedigree. So you see the pedigree, all the 11 children they had and 4 affected. So this was an autosomal recessive missense mutation of the FREM2 gene, which actually pointed towards the principal syndromic form of Fraser. However, an OMIM entry of isolated cryptophthalmos was identified in the children, and this actually points towards the genetic literacy of health-seeking behavior of the parents in the population. This is an 8-year-old boy born of non-consanguineous parents, and the reason for doing a genetic testing was that the parents wanted to know if the half-sibling of this child actually would suffer from similar features. He had attenuated vessels and RP atrophy on fundus examination, and systemically hepatic steatosis, hypothyroidism, and endocrinal abnormalities, but there was an absence of cardiomyopathy. Pedigree was autosomal recessive, but genetic testing, we did not find any evidence to point towards either side, and it came out to be a rare variant of unknown significance of a rare disorder known as the Elstrom syndrome, which affects the multisystem, and it is actually a ciliopathy. So the problem with these patients is that if we do not monitor them vigilantly, they might go into progressive late onset dilated cardiomyopathy. And definitely these patients, the reason why they came to us was actually for the carrier testing, and we actually wanted to go ahead with the carrier testing for the children. So the genetic heterogeneity and the variant of unknown significance presents a challenge in the clinical context of the disease as well as genetic counseling. So when we are shifting from the genetics paradigm to the genomics paradigm, we need to have a well-developed clinical diagnosis before defining its applicability in diagnostic precision of complex ocular disorders of childhood. I thank by saying that we should be learning from every single family that we say. These are my references and my acknowledgements to my mentors and my co-authors. Thank you. Yes, ma'am.
Talking about genomics for each disease will be quite a costly affair. So how do we go about asking for it?
So, ma'am, if we are talking about omics, genomics means then we are talking about the biomics, that is the biochemistry, that we need to rule out all the metabolic diseases first. So omics is better than to go ahead with the genetics. That is the genetics. So if your omics are pointing towards a disease, for example, the Elstrom syndrome, we already knew that he had all the features of Elstrom syndrome. Still the parents wanted to go ahead with the genetic testing. So in this situation, it was only to know if the half-sibling would have the genetics. So they agreed to do the testing. But we feel that we need a robust system where the finances could be supported by some of the companies, although I do not have any financial interest in this presentation, but we need to have maybe a multicentric studies from all the centers, how the genetics is actually affecting at the population level of the children of various diseases. For example, right now we are looking at Usher syndrome. Several centers are put in to look at the Usher syndrome of retinitis pigmentosa. So maybe that is a beginning. We can
Yeah,
look
no,
ahead.
because pediatricians they have no, they have this metabolic disorders which is going on still.
Yes, yeah.
So that is why I was just asking because we are new into ophthalmology
Yes,
having
ma'am.
it.
Yes, ma'am.
Okay.
Definitely. So omics is better. If the omics rule out systemic diseases, then only we can go ahead with the genetics.
Okay.
Thank you so much, ma'am.
I think there is a need for, there are a lot of people in other subspecialties that are going for AI. I think there's a
Yes.
good need for making an app where
Yes.
you can put down, because most of these are syndromes.
Yes.
And you know, when we do our fellowship, that becomes like 20 years back, you remember all the name of the syndromes with their findings.
Yes.
Sort of, you know, it is a culture that when you're doing fellowship, you have nothing else to do, so you mug up a lot of things. At least
Yes.
I used to do it, and I used to enjoy into it.
Yes, sir.
But as the time passes on, you are into practice, you can't remember everything. It is not possible.
Yes, yes.
So it's a good thing. Like nowadays, everything, if you ask somebody, they will Google it and tell you. They
Yeah,
will not
yeah.
be actually doing it. Most of us, when we use OMIM, we do online Mendelian also, we do the same thing. We put
Yes.
it. So why not make an app, or if somebody who has resources, make an app for the pediatric ophthalmologist, for the general ophthalmologist,
Yes,
for the
yes.
pediatricians.
Yes.
At least you come down, you narrow down.
Yes.
As you said, clinically that patient was clear-cut Elstrom.
Elstrom, yeah.
Although you did not show the ERG, did you
I
show?
did, I did, I did.
Okay.
Target adapted ERG,
Okay.
Rogers
So
versus Perles.
I mean, if we have that thing, then most of the things are already sorted out. That
Already,
AI can also tell
already.
you what other investigation you need to do,
Yes.
what is the possibility, and also if you're thinking of Elstrom, what are the other things you should be looking
Yes,
for.
the
I think that
ciliopathy should
there's
be
a
ruled
burning
out.
need for that. That would
Yeah.
be a good paper, rather a good useful tool for everybody.
everyone, actually, everyone, because we do not want to miss out on the children. For example, the syndromic Fraser was there, but it came out to be an isolated cryptophthalmus, which actually had an OMIM entry.
Yeah.
So these patients that
Because
I have
it looks
present-
clearly like Fraser. I
Yeah,
mean, there's
yeah,
no
that is what I
clinically.
said. It
That's the
pointed-
phenotype.
Yeah, that's what I said, that it pointed directly to the principal syndrome of Fraser,
Fraser,
but
yes.
then it came in the OMIM entry for isolated cryptophthalmus.
But then you never know, no, how these genes will phenotype
Yes.
themselves. Like their
Yeah.
manifestation may be slightly different.
Yeah, that is
depending
the
on the
central
environment.
dogma
Yeah.
of this genetics,
Problem.
and uh, I feel we are beginning, and then hopefully we'll come up with something good. Thank you so much.
And if we refer more, then maybe the cost will come down. Is it possible?
Madam, it is actually making an app. Making an app is actually not expensive. Actually, you have to put a lot of data. So making an app will be like, say, 50,000-60,000 rupees. It's not huge. I mean, because I have been developing apps for small things. It's not very difficult to make an app. With a robust institute like yours, or even Arvind Eye Hospital, they have been making apps for so many things. I mean, they have their own department for this. They have people working whole day right for them. So they just need the data. They just have to pull the data, which is already there on net. I mean, they just have to link the API with that particular website, and it will pull the data directly from that. Only thing is that website needs to give them API.
So this was actually an area of complexities that I wanted to know, that different mutations, how they are presenting, what is the frame shift, some have frame
No, of course it was an eye opener. There's no doubt about it. I mean, these things keep coming as free papers, but the whole issue is that as like you are in an institute, that they are big institutes. They have fellows who will, you know, try to find out the nail patella syndrome or some rare syndrome. They will try to find it out. As private practitioners or as general ophthalmologists, there is no, I mean, you don't have a huge response time. Patient is sitting right next to you, and you have to answer the patient what you are having. You can maximum call them the next day, and then you have a huge surgery list. You forget, and the patient comes back to you, and you don't remember what syndrome he has. So this will be a useful tool for everybody, especially for educational institutes. Next, go Lali.
Next paper is free paper 1607, outcome of intravitreal ranibizumab monotherapy in treatment of APRP at tertiary healthcare centers.
Good evening. Today I'm going to speak on the outcome of intravitreal ranibizumab monotherapy in the treatment of APROP at tertiary healthcare system. Now, retinopathy of prematurity, as we all know, is a disorder of the retinal vessels affecting preterm infants. APROP is the most fulminant form of the ROP, which many times progress to direct retinal detachment, stage 4 or stage 5. Two landmark studies, that is cryo-ROP, ETROP, have given their stepping stones for establishing their treatment guidelines, demonstrated satisfactory outcomes of peripheral thermoablation by cryotherapy or laser. But these therapies have not given satisfactory outcomes in the cases of APROP or zone 1 ROPs, because those babies required a larger portions of the retina ablations, and hence in the near greater future they are having myopia, strabismus, amblyopia, and all sorts of poor visual outcomes. In recent times, however, intravitreal anti-VEGF agents have given promising results, especially in these babies having APROP or zone 1 ROPs, by having swift resolution of the plus disease, as well as good retinal vascular development, and requiring less retinal ablation, and giving good visual outcomes. However, though many studies have been there, like BEAT ROP, Rainbow Trials, CARE ROP on these anti-VEGF agents, but there still remains controversy on the efficacy of these agents as monotherapy, and also regarding their safety. However, in the cases of injection ranibizumab, since it has shorter half-lives, both intravitreal as well as systemic, it has been many times used in various studies for retreatment under recurrence cases. So in this study, I have tried to evaluate the outcome of intravitreal injection ranibizumab as monotherapy in the treatment of APROP. It was a prospective interventional study done in a tertiary healthcare system in West Bengal. ROP screening was done as per the national guidelines. Inclusion criteria were patients who diagnosed with APROP and treated initially with intravitreal ranibizumab. They were followed up at least 6 months without any retinal detachments. Patients who were excluded from my study were, of course, those led to follow-up of less than 6 months, or any kind of other form of injections, anti-VEGF outside, or other forms of therapy like laser or cryo before. Also, patients with any kind of systemic infections, fever, leukemia, or eye infections were also excluded from my study. This was the procedure done step by step. And after taking the proper consent, the babies were injected with anti-VEGF injections, and I have selected altogether 12 preterm infants with 22 eyes with APROP. They were re-examined on the day 1 after the injection injected, and also weekly and bi-weekly as necessitated for 6 months. For every follow-up, reappearances, recurrences as well as regressions were taken into account. In cases of the recurrences, a second intravitreal injection was given. An argon green laser was given to those babies who had insufficient responses, either with the persistence of the plus disease, or even after second intravitreal injection, or incomplete vascularization of the retina, even after 45 weeks of the PMA. Now coming to the result, out of the 22 eyes of APROP, 11 eyes were of zone 1 posterior, zone 2 posterior APROP, and rest 11 eyes were of zone 1 APROP. There are some flow charts for coming into my details into the results. APROP after the first injection, there was regression happened in the 45% cases, but recurrence happened in 55% cases almost. In the regressed part, only complete vascularization happened in only 18.2% cases, and the rest remained incompletely vascularized. In the recurrence after giving the second dose administration of the injection, 18.2% of the cases there was persistence of plus disease, and the rest remained incompletely vascularized even after 45 weeks PMA. So except in this complete vascularization group, I had to apply laser to the rest all of it. So it required almost 82% of the cases. Coming to individual zone 1 APROP and zone 2 posterior APROP outcomes, zone 1 APROP had higher recurrences rate, but in zone 1 APROP, all the kids had incomplete vascularization, in addition to some infants who had recurrences, and they had persistence of the plus disease also. So 100% of the zone 1 APROP ultimately required laser. In the cases of zone 2 posterior APROP, there was a percentage of 18.2 percentage who got 36.4 percentage who got complete vascularization. Only this percentage doesn't require laser, but the rest all required laser due to incomplete vascularization at the end of 45 weeks of PMA, in spite of my second injection. So interesting facts I've already discussed about, but another interesting fact was also there, that lower birth weight was directly related. There was statistical significant relation with lower birth weight with recurrence even after a second injection of my anti-VEGF. Coming to my discussion part, such huge recurrences were found in other articles also, and the possible response and the possible reason behind such huge recurrences was told that it was due to suboptimal response of the retina to a rapidly decreased VEGF level due to intravitreal ranibizumab. Also, in another article, it was even mentioned that there were possibilities for extreme preterm infants of having inherent problems of full retinal vascularization due to arrested advancing retinal vascular precursors. So this can be one of the reasons for why I have got the persistence of plus disease only in the cases of zone 1 APROP. Again, lower birth weight was found to have statistical significant correlation with recurrences and retreatment. These were my limitation, and hence I conclude that though injection ranibizumab is emerging as a safe option for the treatment of the infants with lower GI and birth weight, but remains controversial as monotherapy still now, it is of more help in zone 1 APROP to defer the laser and improve the visual outcome by ablating less peripheral retina. Thank you.
Just one question. Did you even include the babies? You are saying low birth weight babies. So babies, those who were in the ICUs, those who had under ventilators or with RDS and all, did you include those, or you have excluded those cases?
Madam, if they were extremely sick, if they had other kinds of those were would affect my studies, like severe sick babies, leukemic babies, low neutrophil counts.
No, that is okay. Those are okay. You have excluded those, but there are certain cases
normal. Yes, madam. Under screening criteria, those were not sick, extremely sick babies, I have taken into account.
Wonderful paper. I think this is one of the. I'm sure that most of the industry people will not accept your findings, but I agree with your paper completely.
Yes, sir. Because I have also done work on laser, but it is giving very poor results to these APROP babies, because still many institutions are sticking to their laser therapies, because still many government institutions are having paucity of these ranibizumab injections. So we had to work on laser therapy for a long time, but giving very adverse outcomes to those babies. Then I have to go with good prognosis babies for anti-VEGFs, and I tried that whether I have to give a laser or not. But only deferring the laser only have helped me, not for
yeah,
for
we
the
agree
final.
with you. Giving the centimeter is good enough in these babies. But one more thing is that even we give it for the patients, those who are even having certain, they are still in the ICU with the ventilator on also, where they cannot, means lasers cannot be given. Even those babies,
Yes,
they
madam,
are
yes,
indicated to be given.
Yes,
They work
of course,
more.
madam, because they are not in a position to take the laser therapy. So my
But
only
still, I don't think so. This monotherapy will.
Yes,
help
madam.
still
I have
this-
also seen it is not working so much, because it is restricting the vasculature after a particular limit. Second injection has not helped it anyway.
Yeah.
So I have to stick to the first injection only.
So how many
And
days gap you are giving between the first and
Madam,
second?
6 to 8 weeks. Whatever the recurrences was happening within 6 to 8 weeks. That's what I have seen in the West Bengal.
Okay.
Thank you, sir.
We had a laser monotherapy arm. They need to get it on. A laser monotherapy arm also along with this, and also we had the option of the second injection, and we had very similar findings with ranibizumab. And surprisingly, the advantage that is given with ranibizumab of lower refractive error and all. So laser and that had similar rates of myopia as the one with ranibizumab, be it one injection, be it two injections. and the second injection invariably still required laser, and that was not the answer.
So that is the reason why we should have open research forums and free papers, and that is the reason why we should attend free paper sessions.
Rainbow is a absolutely biased trial, pharma sponsored. It's not the valid.
I do a lot of ROP, but the problem is that there's nobody ready to understand that this doesn't work. But there is so much of pressure from the industry.
It's a good drug, sir, for posterior zone 1
No,
and
there is
very
no doubt
severe
about
cases.
it.
It's a good drug for that acute phase.
No, we
but
are
it's not the monotherapy answer.
We are not fighting about the drug. We are talking in ROP. It is not something which ends everything. That is the only thing. We are not saying, you see, we cannot. There is some evidence which is already there that it is an anti-VEGF, so it will work like an anti-VEGF. There's no doubt about it. Nobody is doubting the efficacy. Problem is that when you go into the market in practice, I think only the number of people who are sitting here have listened to this, but most of the people in general think that, you give injection, you give
This
two,
is an
what? You
it
give
is not
three.
an alternative to
Yeah,
laser. It is an adjunct to laser.
The thing, you just have some time, that is the thing. Otherwise, it doesn't do much. Yeah, fine.
Thank you, sir.
Now invite Dr. Valimbi Prasad Balachandra.
This topic is novel cloud-based software for binocular vision can help to improve the vision in amblyopia. Dr. Prasad.
Respected chair and the audience. So I'll be presenting the paper on Binox, which is a novel cloud-based software for binocular vision. It can help improve vision and stereopsis in amblyopia. So I absolutely don't have any financial interest in its either the software or the sale of the product or anything of it. So what is this Binox? It's a uniquely designed and comprehensive cloud-based dioptic therapy software for binocular vision assessment and therapy. And since it's a dioptic software, it employs simultaneous and separate stimulation of both eyes using the anaglyph goggles. So it has diagnostic modules as well as therapeutic modules. The diagnostic modules includes the measurement of heterophoria, accommodation facility, Wurzford dot test, color vision tests, and vision tests, and everything like stereopsis and fixation patterns. And the therapeutic modules includes the treatment for asthenopia, for the patients with learning disabilities, and the amblyopia module, which are nothing but the computer-based games which are designed on dioptic stimuli. So this study was aimed to evaluate the effect of this Binox software on visual acuity and stereopsis of amblyopic patients which were aged between 4 to 17 years. So it was a non-randomized, interventional and prospective study. 85 children from my own clinic, so it's a standalone private practice clinic. All children were either anisometropic or ametropic amblyopia. The age group was between 4 to 17. Why not less than 4? Because they were not cooperative for the exercises. And the sex, around 56.5% were males and 43.5% were females. Inclusion criteria, all the patients were diagnosed cases of either anisometropic or ametropic amblyopia, and obviously with associated refractive errors. They had stable vision, meaning thereby there was no improvement with patching on 2 consecutive visits. And they were willing to participate in the study with informed consent. And the exclusion criteria, the patients with strabismic amblyopia or history of any ocular or retinal pathology or ocular surgery were excluded from the study. Pre-Binox, all the patients were evaluated for complete ophthalmic evaluation with a cycloplegic refraction, best corrected visual acuity with a logMAR and Snellen equivalent, and the BAC was tested using TNO test. Since it's a dioptic software, that's why patching was discontinued during the therapy sessions. And post-Binox, that means 1 month after the therapy session and 3 months after the first visit, that is 4 months after the therapy session, Again, the patients were evaluated for complete ophthalmic evaluation with a cycloplegic refraction, best corrected visual acuity, and BSV or binocular single vision with a TNO test. Since it's a software, what were the system requirements? Since it's a cloud-based software, so that's why it was quite user-friendly. So any desktop or a laptop with a minimum of 11-inch LED screen was sufficient. It required a Google Chrome browser, and many of the times, since the study was undertaken during lockdown, so a Google Meet or Microsoft Teams or a Zoom in which the examiner as well as the patients could be connected remotely. Of course, it required good internet connectivity with a minimum of 512 kbps speed. The therapy session, the therapist and the patients could connect even remotely with a Google Meet or MS Teams or a Zoom. Patients needed to use the anaglyph goggles, which are either red blue or red cyan. It required one-time calibration of the patient's computer for the size and the color and also for the anaglyph. And the 30 sessions were given of dioptric therapy, which were given online, and the minimum duration of the treatment was 30 minutes. Observations, it's a whole lot of observations, but what I could observe in the first 1 month as well as 4-month visit was there was definite improvement in vision as well as stereopsis. So of these 85 patients, 48 were male and 37 were female with a mean age of 8.4 years. Pre-therapy, around 22.5% had binocular, best corrected visual acuity of 6, 9 and 6, which increased to 35% post-therapy. So the post-therapy improvement in distance as well as near vision was statistically significant using Wilcoxon sign rank test. And interestingly, improvement in stereopsis was also statistically significant using McNamara test. So according to me, what are the advantages of this Binox software? Since it's a cloud-based program, it's quite user-friendly. It can be used as an easy telehealth vision therapy program. It is useful for patching resistant as well as patching non-compliant amblyoptic children. Because of its remote use, it was of good use even in lockdown as well as in COVID pandemic time. It is given as a game sort of thing, so that's why it's quite enjoyable for the children. An examiner can remotely monitor examination as well as the progress of the patient. But of course, there are limitations of the study. It is just a 4-month study, so the long-term results are yet to emerge. Of course, we are now having this conference in very hi-fi, this thing with a good internet connectivity and everything. But it does require internet connection and desktop and laptop. So still in some parts of India, having internet connection desktop is still a distant dream, so it cannot be universally accepted as of now. Efficacy as a primary treatment also yet to be proved, and of course it requires a long-term studies to prove, because if you see the ATS 18 or 20, even the binocular decourage games, the long-term follow-up, it has showed not superior result than patching. So to conclude, Binox, which is a cloud-based dioptric therapy software, it allowed visual acuity and stereopsis of children between age 4 to 17 years to be improved in their homes for 4 months period, and it requires a long-term studies to prove its usefulness as a robust amblyopia treatment option. These are my references. Thank you for kind attention.
It is costly, I think so.
Sorry?
What is the cost per session, madam?
Cost was much higher, but since I had in fact, I'm quite happy to share, because in a single standalone clinical practice, till yesterday I have recruited almost close to 247 to be precise. So since it's a high volume, I could negotiate with these software people okay. And I could just pass on the benefit to the patient. But as you know, in any new treatment, especially for the amblyopia, amongst ophthalmologists there are either two reactions. Once there is a new treatment, either you go behind it, it's all very good treatment, and on the other hand you just discard it because patching is the only treatment. In fact, as a scientific community, we have to evaluate it properly. It should stand the test of time. It should be evaluated in proper statistical methods, and if it is good, I think we can adopt to these treatments. So it will be interesting to see what happens next year.
No, I think in principle it's a good principle. Yeah. Dioptric is the future. because we are not patching, so we are not removing any
Yeah.
fusion of the patient. But there are free, we use a lot of free
Yeah.
softwares also which are available online. I think apart from the cost and apart from the fact that it can only incorporate mostly anisometropic amblyopsy, though they have a system of adjusting for prisms, it would be too far-fetched to do
Yeah.
it for
Since it's a
still
dichoptic, you need to have straight
you
eyes
need
for
to
that.
have the straight eyes. But I think, and I have used it, I don't think it is very good in, vision deprivation amblyopia, but anisometropic amblyopia, I think it is a fair
Yeah,
thing.
so
to go ahead
4-month period, the results were quite satisfactory.
Yes.
But again, whether it is a long lasting, I still don't know. So I'd be happy to share the
Should
results
be
next year.
long-lasting because should be long-lasting
Yeah.
because it the stereoacuity is also improving, so which shows that it is bifoveal fixation is
Yeah.
also.
So that was quite interesting observation.
You know, we had a Japanese gamer. He used to do virtual games on the world, and he actually worked with the Tokyo Dental College, and he developed a software it's called Blue Vision, BLU, if you go through the net.
Yeah.
You must have heard about him. So he worked with us for 4 months in India, and he was very keen to produce this. Results are fantastic, but the cost was coming to about $800 per this thing.
Cost is always.
Cost is-
when
Yeah,
the
but
new
because of
therapy
my
comes
high
out-
volume, I could negotiate
Yeah, he
with
was
this
looking
thing.
for a VC capital or startup funding, which he couldn't get. But the software that he has is it's been done in Japan, and about 1,000 children is out of the world. Very well done.
Your follow-up was same as that pattern if you are giving it in the remote, like you're just remotely controlling them.
Sorry, I didn't get.
Follow-up, sir. How was the follow-up done?
Follow-up was done in the clinic. Because
In the
in the
yeah.
clinic.
Oh,
That I specifically asked them to do in the
Okay.
clinic. Thank you.
Thank you, sir. May I call upon the next speaker, Dr. Seema Rajan Singh. The safety and efficacy of 27 gauge lens sparing vitrectomy for stage 4 retinopathy of prematurity.
Thank you so much, judges and chairperson. So I'll be sharing our experience on safety and efficacy of 27 gauge lens sparing vitrectomy for stage 4 ROP. I have no financial disclosures. So lens sparing vitrectomy has been established as the standard of care for stage 4 ROP. It started with Dr. Mike Tracy introducing with the 20 gauge systems and 2 ports doing the vitrectomy, but now majority of studies have reported with 23 and 25 gauge very good results up to 70 to 80%. There are only 2 studies available for 27 gauge use in lens sparing vitrectomy from Japan and one from southern India with a very few number of eyes. 27 gauge has potential advantages as it has smaller incisions, better sealing. It's a smaller eye, so that is of great importance. The size is of great importance here. Maybe with the smaller incisions, lesser chances of post-op hypotony and bleeding. That is a major issue in these eyes. And better dissection of the proliferation in ROP because of this cutter tip being closer to the retinal surface. And obviously faster entry and closure time. These are potential advantages that we had in mind to try out. So the idea was to evaluate the safety and efficacy of the 27 gauge LSV. It was a retrospective interventional case series. All patients who underwent LSV 27 gauge for stage 4 ROP between September 2019 and 20 were recruited. Detailed preoperative and intraoperative data recording was already done using standardized performa as a standard done for all the surgeries, and there was a minimum postoperative follow-up of 3 months. So this is the detailed performa that we normally use for our surgical data. It has very detailed preoperative features as well as the intraoperative features, all the complications that can potentially occur to record those as well as the surgical times. So the primary outcome measure was single surgery anatomical success rate at 3 months, and the secondary measures were the iatrogenic complications, wound leakage, secondary loose blood, and the surgical times that took. So this is just a representative case of a 8-week-old infant who presented to us at 8 weeks, 40 weeks post-menstrual age, 1600 grams. And you can see the right eye stage 4B ROP lifting up to the crystalline lens, and the left eye stage 4A. So laser was done in this case, as is for most of these cases prior to surgery, and a week later was taken up for right eye lens sparing vitrectomy. These are just a standard of what we normally do in these eyes. We enter at about 1 to 1.5 millimeter through the pars plicata. The entry is more vertical, and I think this will make you realize how limited space we have to work in these eyes, especially when we are trying to go beyond the limbus. And once all the 3 ports are in, you can see these ports are still budging along the lid margin. So very limited space, and 27 gauge does help a little bit in that. And you can see the detachment that is touching the crystalline lens. So the idea of ROP surgery is not an extensive surgery, it is to cut the vector forces, the disc to the lens traction, the disc to the ridge, and ridge to periphery. You just have to cut these planes and debulk the vitreous as much as possible. Hyaloid removal or any other thing is not an objective, and preventing a break from happening is of prime importance, because once a break happens, you are done with the surgery. So just this, and then we close with a partial fluid air exchange. The fluid air exchange is primarily to tamponade the scleral ports and not for any other purpose. And then in majority of the cases we leave them sutureless, and we check for leakage at the end of surgery. So this is the outcome in this case at 20 days post-operative. You can see the right eye, the detachment has collapsed, and it gets better from here on. The left eye regressed with laser alone. So 27 gauge, initially we had a big problem with the flexibility of the instrument, especially dissecting in the periphery. But with the 27 plus, so this is the Constellation system that we were using, I have no financial interest. They've introduced this extra 1 millimeter sleeve over here, which kind of stiffens that instrument and reduces the bending issue. So we found that 27 plus had greater advantage than 27. We used both in this study. So we had 44 eyes of 31 infants. 10 infants underwent immediate sequential bilateral lens sparing vitrectomy in the same setting. And the mean post-menstrual age at the time of surgery was 42 weeks. So majority of them were being operated right when they were to be born. Stage 4B accounted for about 40% of the cases, and 60% was stage 4A. Almost all eyes received laser prior to surgery. Anti-VEGF was given in 18 eyes. 11 of these was as part of the primary treatment of ROP, and 7 were given preoperatively, seeing the vascular activity in the eyes to reduce the vascular activity. And in those eyes, in 7 eyes, the average time was 4.7 days. Vitreous hemorrhage was already present in 25% as well as pre-retinal bleed. The fibrovascular proliferation was equally distributed between less than 6 and more than 6 clock hours, about 50%. On the outcome, 41 eyes had a minimum follow-up of 3 months, and 73% of them had a favorable outcome. Vitrectomy could be done with 27 gauge in all the cases. The factors causing unfavorable outcome, statistically important, were lower gestational age, less than 28 weeks, and a higher stage at diagnosis, which is kind of expected. And the average procedure times was about half an hour for the total procedure and about 18 minutes for the vitrectomy. The closure time had a higher range, as you can see, because wound leak and suturing the port sometimes takes more time. And complications were lens touch, post-operative fresh bleed, posterior hyaloid contracture, resurgery in 5 cases, and cataract, which all underwent subsequent cataract surgery. Very important point here that for loose blood, in the eyes which received anti-VEGF, none of them had post-operative loose blood. So this was a very interesting finding that we found. We didn't realize that while doing these procedures. So to conclude, advanced cases of ROP can be successfully managed with lens-sparing vitrectomy, and 27 gauge lens-sparing vitrectomy appears safe and effective in the management of stage 4 ROP. A comparison would be in the other gauges would be the next step. Thank you.
Good presentation.
Thank you, ma'am.
Paper, I've used 25 gauge. That itself has bending, so 27 is definitely.
I think they've introduced 25 plus and 27 plus, both of them, and that 1 millimeter sleeve really made a difference. They have increased the cut rate also. That didn't matter much, but that sleeve was very important.
So you're
and
saying
we
that
realized that retrospect. We asked the company people that what's different in your 10,000 cutter, that it's not bending, and that 7,500 cuts was bending. So then they asked their company people, and then they brought out that pamphlet, okay, this is there. And then we examined it under the microscope and actually saw that extra sleeve. So that has an advantage.
So you had that advantage of having that extra sleeve.
Yes, ma'am.
27 plus has
plus.
that.
27 plus. So this study we used both, but it was during this time that we realized that yes, the 10,000 cutters were functioning better for us ergonomically while operating. So
But
that is the major
pediatric-
issue with 27.
With kids, the vitreous is more, the vitreous is more bulky or more
So
thick.
that is
So 27 gauge is
so
good.
the surgical times that I showed, sir, they are comparable to some of the papers that are available for 23 and 25.
Okay,
We couldn't do a head-on comparison here, but we are planning that prospectively.
sure. Great.
Okay.
Thank you.
Agarwal has come. So we'll mark her absent and we'll move on to the next paper.
So the last paper, Dr. Shreya Shah, she's there.
Dr. Shreya Shah has. Anyways, so we will mark her absent, and so there is an announcement, I think.